Hi, I'm Dr. Daniel Greenwald. I'm a medical oncologist and hematologist, and I run the UCLA branch of hematology oncology in Santa Barbara. I'm going to talk today about an overview of our approach to treating both localized and advanced breast cancer and cover some of the exciting new areas focusing on research and treatment utilizing immunotherapy. So we'll start today by giving an overview of how we approach breast cancer, both with curative intent and in an effort to control the disease if it's widespread or, as we say, metastatic. We're going to talk about the historic approaches, the current standards, and some of the cutting-edge areas utilizing the immune system to treat the disease. I'd like to thank Dr. Sarah Hurwitz, who's Director of Breast Oncology at UCLA, who was very helpful in preparing for today's discussion. So I'd like to give an overview of how we approach breast cancer, how it's diagnosed, how it's staged, how we assess prognostic factors, and make decisions with our patients around treatment to either improve the rate of cure from surgery or to extend the life and the quality of life for women with advanced breast cancer. A little bit about the epidemiology. So breast cancer is the most common cancer in women in the United States and worldwide. There's about 275,000 cases per year in the US, and there are about 40 to 45,000 deaths per year from breast cancer. What we've learned over the last several decades is that as we diagnose breast cancer earlier, the chance of curing it outright increases. We've seen a relative decline or steady rate of breast cancer over the last 20 years, and we've seen a drop in the rate of death from breast cancer through enhanced detection as well as improvements in treatment. Screening is essential. What we know is that early detection saves lives. It allows us to capture breast cancer early, where we can intervene earlier and impact the short-term and long-term outcome. We know that mammography in combination with other modalities such as ultrasound and MRI complement each other to allow earlier detection and screening and treatment of breast cancer. So a lot of confusion arises sometimes around how we classify breast cancer. We discuss the histology, meaning how pathologists define breast cancer under the microscope, but in more recent years we're focusing as much on the biology because that determines the clinical outcome as well as the selection of therapy. The language that we use to describe breast cancer reflects the normal biology. So the ducts, which are part of the normal physiology and anatomy of the breast, are formed by the cells, and it's those cells that can become malignant. And so when we use terms like invasive ductal carcinoma, it reflects that there are tumor cells arising from the cells that form the natural ducts in the breast tissue. And there's been an evolution. In the past, we would define things just based on how they appeared on the microscope, and it was more or less a one-size-fits-all approach. And that's evolved by where we're looking more and more at the genetics to help complement what we see under the microscope, and that's leading to more tailored therapy and better outcomes. So initially there's a biopsy performed, and we're trying to find the histologic subtype of breast cancer. We also look at what we call the grade. How angry do the cells look? How similar do they look to normal cells, or how unlike normal cells do they appear? And that reflects the degree of aggressiveness. We also look at key biologic factors. Are the cells estrogen receptor positive, progesterone receptor positive, and do they have an increased copy number or an increased amount of a gene called HER2/neu? All of these affect the biology and the treatment. And we combine this with what we refer to as the stage, which is simply said how advanced or how big or how close to spreading are the tumor cells. These key features or factors called ER and PR, estrogen receptor and progesterone receptor, define the type of breast cancer and very much impact our selection of therapy. In addition, HER2/neu is this oncogene that gets turned on in about 20% of breast cancers. About 60 to 75% are estrogen receptor positive. And we've known for decades that two tumor types that look identical under the microscope can behave very differently, and that was probably explained by genetics that we didn't understand very well. In the mid to late 1990s, DNA array profiling became available, and we were able to look at how genes are turned on and turned off and understand patterns that occur, in turn identifying cells that look identical under the microscope but behave very different clinically. And this has allowed us to parse breast cancer into finer and finer categories, which we understand have different outcomes. So staging. Staging simply reflects how big is the tumor and is it involving the lymph nodes or not. And so from this, we compile a score called stage 0 if it's non-invasive, but it's really a scale of 1, 2, 3, and 4, 4 meaning more advanced. And any cancer, breast cancer that's a stage 1 through 3 is potentially curable. Currently, stage 4 breast cancer is managed to try and control it, typically for years and years, utilizing therapies that keep it in check. Our hope is eventually we will have treatments that can outright rid a patient of stage 4 breast cancer. What we have known for decades, though, is that the higher the stage, as you go from 1 to 4, the lower the likelihood of keeping it in control indefinitely. So in addition to the stage, we do rely on biologic factors, and there have been efforts made to incorporate this into our understanding of the prognosis. What's the long-term outcome? So what about treatment? Well, we know that there's ways of treating breast cancer that have been around for decades, and some of these have not changed and some have changed dramatically. But the backbone of therapy remains surgery to remove a tumor, radiation therapy in some cases to help reduce the chance of breast cancer coming back in the chest, and then a number of systemic therapies that try and augment the overall rate of cure of breast cancer. All of this started in the 1800s, and it was based on a theory at the time that cancers would start in one area and just move slowly out from that area. What was not appreciated at the time is that cancer cells have the ability to jump into the bloodstream or into the lymphatics and land in distant areas and arise. And what came out of this initial theory were increasingly extensive, if not barbaric, surgeries, where the belief was that if you could remove as much tissue in the chest as possible, you would increase the likelihood of cure. And that really stood until about the late 1960s and early 1970s, when it was recognized that you could do less aggressive surgeries, and in combination with radiation, as well as systemic therapy, achieve better outcomes without so much morbidity and disability from surgery. This was studied and championed by a surgeon named Bernie Fisher, who did some of the most important studies showing that lumpectomy with radiation was as effective as mastectomy. And more than 20-year follow-up established that this remained an effective standard. It would be combined with radiation, and again, radiation is really utilized to try and reduce the likelihood of a breast cancer coming back in the chest or under the arm. And that's been also proven with long-term follow-up. So what about systemic therapy? So many people in the public, either through close friends and family or just being aware of what's available in modern medicine, understand that chemotherapy, which is really a collection of different chemicals which can have considerable toxicity, is sometimes used in treatment of breast cancer. But in addition, we use increasingly biologic therapy and what we call endocrine therapy or hormone therapy to control some types of breast cancer. And so there's an important concept, which is that at the time of surgery, there's a chance that some cells have broken free and are hiding in the body, too few in number to detect, too difficult to assess with our current technology. And while they're there few in number, there's an opportunity to wipe them out, in some cases with chemotherapy, in some cases with endocrine therapy or estrogen blockade, in some cases with both, to improve the overall outcome or the overall rate of cure of the initial surgery. And that is either given after, as we've referred to as adjuvant to surgery, meaning adjunctive or in addition to, or sometimes given neoadjuvant, which is medical Latin for before surgery. The real advantage of giving it before surgery in some cases is we can see if it's working by watching the primary tumor shrink, and sometimes it can enhance the surgical outcome. But at the current time, we don't believe that one is necessarily superior to the other in terms of improving overall rate of cure for most breast cancers. So chemotherapy works by eradicating or killing rapidly dividing cells. Obviously, it works in some cases better than others, and it carries considerable toxicity, which can vary from individual to individual, but also from one type of chemotherapy to another. And when we decide to use chemotherapy, we make all the efforts possible to reduce the short-term and long-term toxicity and reduce immediate side effects, such as effects on the immune system. Clinical trials have demonstrated that for some types of breast cancer, chemotherapy can considerably improve the rate of cure in addition to surgery or surgery and radiation. And it can also be used before or after surgery, depending on a number of circumstances. Well, so targeted therapy tends to be more specific to a tumor cell and less to normal cells. And the prototype of this for breast cancer is estrogen blockade, but it requires an understanding of the biology. And so in the case of breast cancer, we tend to use this only for those cases where the estrogen receptor is present or positive. And so the prototype drug for this is tamoxifen, which is a drug that blocks estrogen from hitting its target. In the 1990s, it was shown, or in the 80s and 90s, it was shown that this could reduce the risk of recurrence of breast cancer, and maybe in some cases even prevent breast cancer in certain instances. But in the 1990s, we started to study a more potent version called aromatase inhibitors, which rather than blocking estrogen from hitting its target, actually block the production of estrogen in the first place. And so there are 3 of these that we use, all generic now: anastrozole, letrozole, and exemestane. And they do have a marginal improvement over tamoxifen, but carry a different set of toxicities and considerations. We only use these after menopause because of the function, and tamoxifen or like drugs have to be used before menopause unless there's an effort to induce menopause either chemically or surgically. So what we do know is that for estrogen receptor positive breast cancers, blocking estrogen improves the long-term outcome. It reduces the risk of recurrence, and this is typically applied for 5 to 10 years, depending again on a number of circumstances. Understanding that the estrogen pathway plays a role in driving tumor cells to grow, a lot of basic science has been conducted over the last 20 to 30 years. And out of this arose the realization that there are other signaling pathways that make these cells grow. A really interesting pathway that was targeted just in the last decade was looking at something called the cyclin-dependent kinase. And all that is an enzyme that makes tumor cells grow. By looking at a group of estrogen receptor positive cell lines that grow in the test tube, it was recognized that by blocking this, we could actually reduce their growth. And so in comparison to other types of breast cancer, the estrogen receptor positive breast cancers could in theory be treated with this medication. A lot of very exciting basic science led to work in animal models and then eventually in humans. And there was a fairly rapid development of these drugs, which are now used in the clinic. So first was palbociclib, followed by ribociclib, followed by abemaciclib. So these are drugs that are used for advanced breast cancer and remain under study in early stage breast cancer to see if we can further improve the cure rate of our current methods. Well, there's also this category I mentioned before called HER2 positive. That was first characterized in the mid to late 1980s. It was recognized that this is about a 20% population of breast cancer that behaves very aggressively. And understanding that led to the development of treatments by the late 1990s and early 2000s, which has also really dramatically improved the overall rate of cure of early stage HER2 positive breast cancer, as well as the outcomes for advanced HER2 positive breast cancer. And it's a good segue into immunotherapy because the main way that we treat HER2 positive breast cancer is by using an immune protein called an antibody. So you hear a lot about antibodies in the context of things like COVID-19. Antibodies are our main ammunition that our immune system uses. If you get sick with the flu, your body produces billions upon billions of antibody proteins that circulate in the blood and provide immunity to it. But we can also exploit these immune proteins in treatment of cancer. Sometimes they directly attack a cancer and lock onto it to provide immune function, and sometimes they simply act like a blocking protein that will prevent something from being activated. Just to put in context, looking at our example here, if you take a small molecule like aspirin, it's just a few atoms. It's very small. Those tend to be pills. Larger proteins that we use, for example, to support white blood cells, tend to be injectable under the skin, but you can't swallow them or they'd be digested, just like a meal. And then larger proteins yet are these antibodies. They're considerably larger. An analogy we'll often use is a bicycle to a car to a jet aircraft. And so in the late 1990s, early 2000s, an antibody was developed that would block HER2, or HER2/neu, and that is produced in a factory. It's not made in an animal. It's not made as a vaccine, but it blocks that gene on the gene product on the surface of these tumor cells in combination with other therapies has pretty significantly improved the overall rate of cure for early stage HER2 positive breast cancer, but really extended the lives for women with advanced HER2 positive breast cancer. In addition, because antibodies are by definition engineered to lock onto a specific target, for example, a flu virus or HER2, they can act as a Trojan horse to deliver a toxin into cells. This concept has been around since the early 1980s, but the technology has gotten better to deliver things more cleanly with fewer off-target effects. And that's led to what we call antibody-drug conjugates. So it's kind of an immune therapy, but it's really just a delivery device for some other type of treatment into just the tumor cells, avoiding as much exposure to the normal cells. And some of these are available now for HER2-positive breast cancer. And so, in addition, we found better ways of developing antibodies that target other forms of HER2, and we now have a drug called pertuzumab that complements trastuzumab, that's Herceptin and Perjeta, for treatment of HER2-positive breast cancer, further improving the complete remission rate for early-stage disease, and we believe the outcomes for advanced disease. One area that keeps oncologists up at night is triple-negative breast cancer. It's an area where we have fewer targets and therapies are desperately needed. And a lot of the focus on immunotherapy and the current usage is in this area. These tend to have a much more aggressive course and a much more inferior outcome. So one recent development is the use of one of these antibody-drug conjugates, where the metabolite of an old chemotherapy is delivered just primarily into the bad cells. It does have some side effects, but it allows for considerable regression or remission in many of these triple-negative breast cancers when utilized in combination with an immune protein. But as far as immunotherapy goes, it's a little bit different than the way we conceive of immune therapy, which we'll get to in just a moment. So just to review, localized breast cancer is often curable. We do everything we can to tailor a program to improve the rate of cure, either through chemotherapy in some cases, chemotherapy with an immune protein like Herceptin or Perjeta, or hormone therapy, or some combination thereof. Breast cancer, when it has recurred or is advanced, is something that we try and manage as best as possible as a chronic disease, for which there's a lot of areas of active research looking into new treatments, and most importantly, an area of research for immunotherapy. So what is immunity? Immunity really is the ability of a human, or an animal for that matter, to distinguish self from non-self. It's how we fend off infection. And it's been recognized for a long time that tumor cells really acquire the ability to escape from the immune system. We know that in cases where the immune system is suppressed, certain cancers are increased in their prevalence or in their clinical behavior. And so it's long been recognized that certainly certain tumor types have the ability to evade the immune system and ought to be an attractive area to treat. And this is not a new concept. This goes back to the 1890s when a surgeon in New York recognized that patients with sepsis sometimes developed a partial regression or a shrinkage in their tumors. Not a lot was understood about the biology, and it was probably related to immune hormones that have anti-tumor effects, some of which were studied heavily in the 70s and 80s, but do have a bit of excessive toxicity, and frankly, in the end, were not terribly effective. But it established this idea that perhaps the immune system could be used to treat cancer. And there were some very early crude attempts at using inactivated bacteria to treat sarcomas or malignancies in the 1800s and early 1900s. And not a lot happened clinically, but a lot of basic science was conducted over those interval decades. One of the biggest breakthroughs occurred in the early 80s when actually a patient from Santa Barbara was treated on a clinical trial with an antibody, much like the ones I've described for his lymphoma. And that was using a very labor-intensive, very custom-designed immune therapy made in a lab utilizing actually a mouse to create this. But he had a tremendous response and lived an additional 30 years. And it spurred a lot more interest in using active immune therapy to treat cancers. Another big breakthrough occurred in the mid to late 1990s, which was the recognition of what we call checkpoints. These are on-off switches for the immune system that tell the normal immune cells, hey, stand down and don't attack or launch an attack. And it was recognized that tumor cells had the ability to hijack essentially a cloaking mechanism or an on-off switch and hide from the immune system. That led to the development of ipilimumab, which was the first, followed by a number of other medications to treat melanoma, a very aggressive, very dangerous skin cancer. And the first approval of this occurred after some studies approximately 10 to 11 years ago, followed by many, many more studies and many applications in other areas of oncology. And so these so-called checkpoints, what we know as PD-1, PD-L1, it's kind of a lock and key that tells the immune system either back off or attack. One other analogy I will often use is a bit like a parking brake on the immune system, coupled with this cloaking mechanism analogy we just discussed. And so by blocking these with a therapeutic antibody, just like Herceptin, but targeting at this either PD-1 or PD-L1, two sides of the same coin, we can see responses and remissions in a variety of tumor types. And this is one of many of these that are now utilized in the clinic, and these are the indications. So we're using immunotherapy right now in the clinic with dramatically better outcomes than we had 10 years ago or 20 years ago for a subset of a number of different tumor types. And you can see from the list here, it includes things like advanced melanoma, lung cancer, kidney cancer, bladder cancer, other forms of skin cancer, Hodgkin's lymphoma, subsets of head neck cancer, esophagus cancer, and so on. It's really been an exciting time. And in the field, for those of us who conduct research, it's a time to build upon this success and figure out how do we get these drugs to work for more people with fewer side effects. And that's the challenge of the next decade. And more importantly, how do we get these to work for diseases for which these current versions don't work as well as we would like pancreatic cancer or advanced breast cancer. So what we know is, or what we currently use is FDA-approved drugs in the clinic, and we study drugs that either FDA approved for one indication being studied for another, or under development and study for a new indication. And what we know is there are certain factors that increase the likelihood. I mentioned if you have a disease like melanoma or lung cancer, there's times where these drugs work spectacularly and other times where they don't work terribly well. And there's certain factors we look for to try and determine that in advance. It includes the presence of that target, PD-1, PD-L1. It includes whether the tumor is very damaged at the genetic level. Turns out the more damage, the more likely the immune system is to recognize it, and that we can use that to our advantage. There's a subset of tumors that have a certain genetic signature we call microsatellite instability. It's kind of a version of an inherited susceptibility to cancer, but you can also acquire it. And those tend to respond better to immunotherapy. So much so that you can have any tumor type of any tissue, but if you have that pathway present, something we look for, we can use immunotherapy successfully. And it's something we look for virtually every type of tumor if we're thinking about using immunotherapy. And so there is a lot of interest in combining these immunotherapies with other forms of targeted therapy that turn off certain gene products, other forms of immunotherapy, other, as we call it, checkpoints, other on-off switches for the immune system, as well as other modalities of treatment, including standard chemotherapy or radiation, which may actually enhance immunotherapy by exposing proteins from a tumor to the immune system that they may not have otherwise seen. So one of these is pembrolizumab, has a brand name, and it's used for a number of those tumor types I just mentioned, but it's one of the few that's currently approved and labeled for treatment of a very specific subtype of breast cancer, and that's specifically high-risk, early-stage, triple-negative breast cancer in combination with chemotherapy, and then either continued as a single agent after surgery. And more can be found about this online. But this is something that we're currently using in the clinic, and again, trying to build upon in additional research studies. The reason it's approved and the reason we use it is the main endpoint was, can we increase the likelihood of wiping out all the tumor cells if we give it before surgery at the time you get to surgery? And based on that, as we call it, remission rate or pathologic complete response rate, it was given approval for use in this setting. And so it also seems to improve event-free survival, which is a statistical term that people that do clinical research utilize. It simply means from the time that you enter study or treatment, how much of an interval can occur before there's an event, such as a recurrence or a problem. But there's a lot of focus on, does this impact the overall survival? And that's one of the areas that's under continued study, looking, can we effectively improve the cure rate? That's certainly the hope. Now, there's a saying in drug development and research, which is there's no free lunch. And much like chemotherapy has lots of side effects that we really try to prevent or mitigate, immunotherapy has some risks as well. And just like we can attack a tumor with our own immune system by triggering the attack with these types of medicines, sometimes there are innocent bystanders. And the immune system can attack parts of the body, causing what we call autoimmune problems. And this can occur really anywhere in the body, or as doctors like to say, any type of itis, any type of inflammation in the body. It could be the intestine, could be the lungs, could be the kidneys. And it's important for the treating clinician to be on the lookout for these, to ask patients about symptoms, side effects, to identify these, and to treat them. In most cases, these can be treated successfully, but they have to be identified and recognized. And so, looking at the horizon, there's a lot of new targets, and it's really an exciting time. If you look at what's happening in the basic science laboratories all over the world, our knowledge of how the immune system functions and our ability to kind of turn it on and off is improving with a lot more precision than we've ever had. So very methodically, this is leading to rationally designed treatments that will roll into the clinic over the next several years. What we're looking at are combinations, as I mentioned, with oral inhibitors, combinations with co-stimulatory molecules, other things that turn the immune system on. As I mentioned, radiation therapy, which can increase the target for our current immunotherapies. We're looking for new surface targets, new ways to attack tumor cells that make them distinct from normal cells. There's a lot of interest in an area that's related to immunotherapy, but cells have various types of cloaking mechanisms, including what we call a do not eat me signal. And it turns out that turning that off may enhance the immune attack on cells, including breast cancer cells. There's new forms of antibody structures where antibodies are designed not only to lock onto a tumor cell, but directly pull in the immune cells. And then one of the most exciting areas is what we call cellular immunotherapy. This is a new area. It's currently being used and currently FDA approved for treatments of certain types of leukemia and lymphoma. But this is where your own immune cells get removed from your body and effectively reprogrammed with DNA to then go back in and attack a tumor. We say reprogram almost like we talk about software, but they have DNA inserted in them, which essentially instructs them to go after a specific target in a tumor. It's a very labor-intensive process. It takes several weeks to get prepared for it. It's unfortunately very expensive, and there's a lot of effort to look in ways to make it more efficient and hopefully more cost-effective over time. But an area of active interest is in breast cancer, and currently I would say that these are in the very, very early stages. There have been a couple cases treated at a couple institutions with very custom-built forms of CAR T-cell therapy, but there's a lot of interest in the academic side as well as the commercial side in exploring this as a form of treating breast cancer. So this is a short synopsis of the current studies utilizing immunotherapy in treatment of breast cancer in the United States. So when we conduct clinical trials, they're divided into phases. There are what are called phase 1, which is typically first in human. We're really trying to establish the dose, is something safe, and see is there a signal, does it look like it works? Phase 2 trials are really to understand how well a drug works. They tend to be open label, single arm. The doctor knows what the patient's getting, the patient knows what they're getting, and they tend to be larger than phase 1 trials to really kind of fine tune whether a medication or a treatment is working. And then so-called phase 3 trials tend to be a scientific experiment conducted on a population of patients that volunteer to be treated. By definition, it often requires a comparator. So for regulatory reasons, there has to be some reasonably effective standard to which we might add a new medication to understand, does that new medication work better than the current standard, either alone or in combination? And there are oversights of these types of studies to ensure that if there's a clear early benefit, that a trial might be stopped and allow for access to a medication if it's effective. But the fact that we can see there are a greater number of phase 1 and phase 2 trials and fewer phase 3 tells us that we're in a ramp-up phase of immunotherapy studies for breast cancer. Now naturally, some things don't pan out in phase 1 and phase 2 and they fall off by the time we get to phase 3, but there's a lot of early stage testing going on right now utilizing various forms of immune therapy and treatment of various stages of breast cancer. So currently, I'm just going to review trials that are being conducted by the Division of Breast Oncology at UCLA, focusing on those that are using immunotherapy. So a program as large as UCLA with 19, 20 sites with multiple faculty in multiple different parts of Southern California. There's a large population, and breast oncology is one of the strong points of UCLA's program, both by its legacy, its current research, and its infrastructure. And so there's an effort to identify needs and areas of needs and understanding where can we get the best available cutting-edge therapy to those patients, in this case, women and men with breast cancer who need therapy. So we parse these into the different types of histology, the different stages, the different scenarios where somebody may have had a certain number of lines of therapy and have access to a newer approach. In the case of immunotherapy, there's interest in looking at adjuvant therapy, meaning, again, adjunctive to early stage curative surgery for HER2-positive breast cancer. There's an interest in looking at metastatic triple-negative breast cancer, which has a worse prognosis than other forms like estrogen receptor positive. And there's an interest in looking at novel combinations that are specific for certain mutations. And that's something that the oncologist works with the pathologist in the laboratory to determine. But at any given moment, there are typically between a dozen to 3 dozen different types of trials open just for breast cancer. In addition, for HER2 negative breast cancer, hormone receptor positive, there is interest in using a form of immunotherapy in combination with hormone therapy, and that trial is currently open for patients with metastatic disease. So if there are ever questions about eligibility for a trial, I would encourage somebody to contact their own oncologist, who usually is in close contact with regional referral centers, and there are trials being conducted here in Santa Barbara as well. So in summary, breast cancer is common and still a great source of morbidity and mortality in the United States. However, outcomes are better than ever. We're utilizing increasingly tailored therapy to improve the cure rate of early stage breast cancer and enhance the outcome for women with advanced breast cancer. A lot of this is determined by what we see under the microscope, but a number of biologic factors that are increasingly allowing us to tailor therapy in a way that we couldn't do 10 or 15 or 20 years ago. Survivorship is increasing, and survivorship has become an important area of interest for oncologists, as we expect we maintain care and follow-up for years to decades following a diagnosis of breast cancer. I'd like to thank you for listening to today's talk. If you have any questions, I would refer you to the Breast Cancer Resource Center, a very valuable local resource for women who are coping with breast cancer, as well as family members who are coping with caring for patients with breast cancer. And any of the oncologists locally in Santa Barbara are a great resource to talk to regarding these kinds of treatments as well as research treatments. Thank you very much.